So you've probably seen quite a lot in the news recently about this party drug everyone seems to be taking called GHB. It's really prevalent in the party scene at the moment, and it's been around for quite a while. It usually comes in a liquid form, can also come in a powder, and depending on the type of salt used to make it, it can be tasteless or salty, so it can be easily masked in drinks, which can be a bit of a problem. It's a drug that's been around for a while, and it was primarily used by bodybuilders throughout the 80s and 90s because of its effects on human growth hormone. Now it's commonly used as a party drug, partly because of its increased euphoric effects and increased libido. And the unfortunate reality is it's also used in a lot of sexual assault cases because of its sedative effects. So GHB's pharmacology is partly understood. The drug is a weak GABA-B agonist. This is where it gets its hypnotic effects. This is a G-coupled protein receptor, and they can stimulate the opening of potassium channels, which reduces the frequency of action potentials, which in turn reduces neurotransmitter release. So GABA-B is considered an inhibitory receptor. The second receptor GHB works on is the GHB receptor. This is still being researched, and we know a little bit about it at the moment. It's another G-coupled protein receptor that stimulates the release of glutamate, which is an excitatory neurotransmitter. The GHB receptor is densely packed in areas of the brain, such as the hippocampus, prefrontal cortex, and other areas like the amygdala. And this is responsible for the excitatory effects of GHB. So if we're going to draw it out, here's a GABA-B receptor in the red and GABA-A in the blue, and the white part's the cell wall. As GHB attaches to GABA-B, it sends a signal for the channel to release potassium from the cell. So activation of GABA-B modulates the opening of potassium channels, causing intracellular potassium to exit the cell, leading to cell membrane hyperpolarization, inhibiting the action potential. GABA-A, when that's activated, that allows chloride to enter the cell, resulting in further cellular hyperpolarization. So GABA-A is also the molecular target for benzodiazepines. This can have various effects with GHB because alcohol, benzos, and other drugs work on the GABA-A receptor. The effects of GHB can last for about 1.5 to 4 hours and longer if bigger doses have been taken. So you can sometimes see convulsions and agitation from GHB, and these can be treated with benzodiazepines. Even though they're CNS depressants, they work primarily on GABA-A, whereas GHB is primarily a GABA-B agonist. So it doesn't worsen the CNS effects as much as we might think. So what are some of the things that might affect GHB? We've already talked about alcohol, other drugs. Because GHB is absorbed in the gut, fasting can actually have an effect on the blood plasma concentration. So if you haven't eaten anything, you can get a rapid rise from this drug, and then you get all the negative effects associated with it. Secondly, GBL, which is a prodrug to GHB, it's actually broken down by the liver prior to absorption. So this increases the bioavailability of the drug by about 2 times. Another thing is GHB has a very narrow therapeutic window. So this means the dose response curve is altered. Makes it very easy to overdose on this drug. So if we're going to plot it out on a graph, compared someone who's eaten and someone who hasn't. So we've got the time and the blood plasma concentration. The red's someone who hasn't had anything to eat. And what you'll see is once they've absorbed the drug, there's a rapid increase in their blood plasma concentration. And this is where you get a lot of the negative effects. And in the blue is someone who has eaten. There's a slower absorption. So some of the CNS effects of GHB vary, and this depends on the receptor targets. It's quite common to see euphoria, agitation, coma, fluctuations in conscious state, myoclonic movements, and drowsiness. Respiratory effects include respiratory depression, loss of airway tone, obstruction from, let's say, vomit, or Cheyne-Stokes respiratory patterns as well. Other effects include bradycardia, hypotension, vomiting, and nausea, and you'll commonly see bradycardia and hypotension in someone that's taken GBL. The unfortunate thing is that they don't know what they're taking, whether it is GHB or GBL. So how do you treat someone who's overdosed in GHB? Primarily in the pre-hospital setting, usually observation, sedation if they're agitated. They can be quite difficult to manage. Protect the patient's airway. So position, suction if needed, get some vomit out of the airway. Airway adjuncts to maintain a patent airway, so like a nasopharyngeal or oropharyngeal airway. And intubation if necessary to protect the airway from vomit, or if further management is needed. Oxygen supplementation as well. And if you need to correct hypotension and bradycardia, usually fluid administration. So this was just a quick rundown of GHB. There's probably a couple of things I missed or might have got wrong, but feel free to leave it in the comments section if there's anything that you figure out. This video isn't used to advocate drug use or anything, so if you are going to use it, just be safe. It's mainly for educational purposes, and I hope you guys enjoyed the video.